and also the PDF. Once you finish, I'll just share the PDF of your
Okay.
presentation on the email.
Okay. Okay.
I'll upload that. That becomes a good study document for everybody.
That's right. That's right. Actually, for my FRCPath, since I was doing neuro for a long, long time, and I gave this exam quite late. So there were, at that time, there were not many online lectures available, but there were a few, and those are the ones which really helped me,
Yeah, it
you
does.
know.
Yeah,
So it's a very good way of, you know,
right,
learning.
right. We are about to start.
We'll start now.
Yeah,
So it's
just give me a
7.
minute.
All right.
7:29.
All right. Go, you have to be around. I might fumble a bit, be in this chair. Children are
Good
very
evening.
smart. Sorry.
Yeah. Good evening, everybody. Welcome to this evening episode of Neuropathology Pursues 7B. And we are streaming live from Bengaluru via Kolkata. And we are from Sakra World Hospital. And with us, we have Dr. Nandita Ghosal. She's an MD from AIIMS Delhi, FRCPath. She's a specialist pathologist with Sakra World Hospital, also a visiting senior consultant with Sri Sathya Sai Institute of Higher Medical Sciences. She's got a vast experience in neuro-oncology, more than most 17, 18 years of experience in neuro-oncology, and more than 100 publications in various indexed national and international journals. And she is here today to discuss a very, very important topic, that is approach to brain tumors, in particularly with gliomas and embryonal tumors. And before I ask her to start, I would request everyone to keep your mic muted. Please keep your camera off, and please don't share your screen. When you log in by joining now, and please don't press present now. With this, I would request Dr. Ghosal to take over, share her screen, and start the session. Ma'am, please share your screen.
All right. Go, come here. Hey, present now.
I can see your screen coming in. Yes, make it full screen.
Yeah, is it okay now?
Absolutely fine. Start, please. Thank you so much.
All right, go. Yeah, just check. My camera is on, right? Dr. Nadine? You just put it on? It's on, all right. Okay. Then go to my presentation. Yes.
Yeah, please share your presentation. Yeah,
All right. So shall I
fine.
start now?
Please start.
All right. Good evening, everyone. Today, my topic is approach to diagnosis of brain tumors. My focus will be on gliomas and embryonal tumor. I will be emphasizing predominantly on the histomorphological diagnosis of these tumors. We'll discuss the differential diagnosis, mimics, some of the typical features and some of the atypical features, and how to sort out a difficult case where there is overlapping features between the tumors. Briefly, I'll also talk about frozen section diagnosis of some of the brain tumors. Please note that I am not going into the molecular details of these tumors, although there are lots and lots of molecular data which are coming up, and I will just brush through C impact now so that you can familiarize yourself to the changes or additions which are going to come in the upcoming fifth edition of WHO. So without further ado, Let us get started. So you can see my first slide. This is an image from our revised fourth edition of WHO tumor. And if you see carefully, presently we are following this. And astrocytic and oligodendroglial tumors, we give a layered or integrated reports wherein we combine the histomorphological features and the molecular data. Therefore, we have these categories, that is IDH mutant, IDH wild type, and NOS category. In addition, there are a few more entities which have been added in the list. For example, epithelioid variant of glioblastoma, anaplastic pleomorphic xanthoastrocytoma. Then we have diffuse midline glioma, H3K27M mutant, so on and so forth. Furthermore, you can see that in this current edition, some of the terminologies and some of the entities have been deleted. For example, gliomatosis cerebri, protoplasmic fibrillary astrocytoma, cellular ependymoma, they are no more there. The terminology PNET doesn't exist, and there are a couple of additions. For example, brain invasion is considered an independent criteria to diagnose atypical meningioma, which is WHO grade 2. There is merging of solitary fibrous tumor and hemangiopericytoma group, and their histomorphological features as well as the WHO grading have been very nicely defined in this fascicle. And then there are some of these newer or the variants of the glioblastoma and also the ganglion cell tumor which have been described. Coming to the C impact now. What is C impact? It is consortium to inform molecular and practical approaches to CNS tumor taxonomy, not officially WHO. So basically, what these people are doing, there are a total of 7 updates which are being periodically published since 2017, and lots of molecular data is being published in the CNS tumor. And what has been found is that there is different prognosis in the molecular subgroups of similar grade tumor. So therefore, there are a couple of recommendations which have been proposed by the C impact now group. So what are they? The first comes IDH wild type astrocytoma. So if there is an IDH wild type diffuse astrocytoma, which is either grade 2 or 3, they should be further subjected to molecular analysis for these 3. And if we see any of these molecular aberrations, then that wild type diffuse astrocytoma, what is the terminology which will be used? IDH wild type diffuse astrocytoma with molecular features of glioblastoma, WHO grade 4. Now, what should be noted is that these Roman numerals have been replaced by these Arabic numerals. Similarly, for the IDH mutant astrocytoma, if you are seeing grade 2 or 3, they should be subjected to this molecular test. And if you see this, that is CDKN2A/B homozygous deletion, or microvascular proliferation and or necrosis, which is already described, or any combination of these features, we are going to term it as IDH mutant astrocytoma, WH grade 4. Note, IDH mutant glioblastoma term is not there. These are further recommendations. For example, diffuse midline H3K27M mutant glioma. Now, the definite criteria for this glioma has been proposed, that it has to be diffuse, it has to be in the specific location, it must show H3K27M mutation. Then only you will call it as diffuse midline glioma H3K27 mutant. Now, for example, in a brainstem, in a child, you are seeing histomorphology of pilocytic astrocytoma. And radiologically also, it is a well circumscribed lesion. Are you going to do H3K27M mutation analysis? The answer is no. Similarly, there is clarification of the NOS and NEC. Keystone mutated glioma in the cerebral hemisphere have been defined like H3G34 mutant. Then there is classification of the ependymoma according to the sites and the molecular subgroups. Anaplastic term has been removed from ependymoma. So if you see an ependymoma, you just write it ependymoma and write the grade. Again, note this is Arabic numeral. Another interesting thing is that the myxopapillary ependymoma, which currently we grade as grade 1, has been upgraded to 2. Then there is molecular classification of pediatric and young adult glioma. There are a couple of newly recognized tumor entities. So these are the different things which are there in the C impact now. And in case you want to know the details of this is all available online and you can check it. So now coming to my main topic, that is the histomorphological diagnosis of gliomas and embryonal tumors. So let us get started. This is my first case. As you can see in the slide, the diagnosis is already there in the slide. So why there is a reason why I have already put the diagnosis on the slide, and the reason is I don't want you to tax your brain on inferring what it is. What I want you to concentrate on is what is the cytomorphology, what I'm going to discuss. So this was an 8-year-old boy. He had a posterior cranial fossa mass. It was well circumscribed. It was cystic and solid. There was a mural nodule, and this is the squash preparation of the slide. What do you see in this? You can see that it is a glioma. I can tell it. And how? Because if you see these cells, can you see these hair-like processes coming out of the cells? And look at this. They are so thick. They are so enmeshed with each other. So this is a piloid kind of morphology, all right? And then you can see this pink globular thing, slightly granular. This is eosinophilic granular body. And then we have these rosenthal fibers. But what I want you to notice in addition is that there is a lot of nuclear pleomorphism, if you see, including giant cells. Some of the nuclei are so big, right? But still, it is pilocytic astrocytoma. Why? Because when you see the radiology, which is well circumscribed, you know the location, you know the age, you are seeing this kind of a squash preparation wherein you are seeing varied, there's some amount of pleomorphism, but there is eosinophilic granular body. There are these piloid processes. There is this rosenthal fibers. Believe me, it can be nothing other than pilocytic astrocytoma. This is again a paraffin picture. You can see that. This is a book picture wherein in a paraffin section of a pilocytic astrocytoma, you see a biphasic tumor where you have this piloid foci intermixed with this microcystic foci. But believe me, many a times out of 10 cases, 6 will fit into this, but 3 will be there which are going to give you trouble. So we have to remember some of the clues which will take us to the right diagnosis. All right. So some of the atypical features which we can see in pilocytic astrocytoma is this. Can you see these cells? They have got this perinuclear halo to it. This almost looks like an oligodendroglioma. But is it an oligodendroglioma? Answer is no. This is an oligodendroglial-like cells which can be seen in pilocytic astrocytoma. And then you see this picture wherein you are seeing there is lots and lots of vascularity. Actually, pilocytic astrocytoma can not only show increased vascularity, but it can show microvascular proliferation. It can show sometimes infarct-like necrosis. Then how do you come to the diagnosis? Again, you have to see those features which I described. You have to see the location. You have to see the age. You have to see the radiological details. And then only you can come to the final conclusion that what tumor it is. So, as I told you, pilocytic astrocytoma is a WHO grade 1 tumor, well circumscribed, majority in the pediatric age group, commonly found in the cerebellar hemisphere, optic chiasm, hypothalamus, thalamus, and basal ganglia. It's a biphasic tumor most often, showing rosanthal fibers, eosinophilic granular bodies, POP giant cells. As I told you, these things can be seen, for example, in FARC-like necrosis, MVP, so on and so forth. Very rarely you can see leptomeningeal spread, but that's rare. If you see brisk mitosis in a tumor which is showing morphology like a pilocytic astrocytoma, it must raise an alarm. All right. So then you have to really look into it properly. In fact, the C impact now recommendation in the newer entity, we have a high grade astrocytoma with pilocytic feature. That entity is also there. All right. So more than 70% of these pilocytic astrocytoma show KIAA 1549 BRAF fusion protein. Having talked about the pilocytic astrocytoma, I go on to the next, which is Pilocytic astrocytoma. Now, this was also a young boy who had a tumor in the hypothalamic region, and this is what we saw. Now, in this tumor, you are seeing that there are these cells which are more or less, sort of spindle, but again, they have these cytoplasmic processes here, almost like hair-like projections coming out of the cell. And look at this angiocentricity of these tumor cells. They're all arranged around these vessels. And then the point to be noted is that in between the tumor cells, you are seeing this myxoid material, which is there all over it. All right. And this is the Alcian blue, which is further showing you beautifully this myxoid matrix, extracellular matrix, which is there. Again, the angiocentricity, monophasic kind of tumor looks sort of, not at all high grade. I didn't see any mitosis, I didn't see any necrosis and microvascular proliferation. And this is the GFAP immunohistochemistry, again, beautifully showing the, angiocentric arrangement of the tumor cells. So this is a Pilocytic astrocytoma. This is actually a variant of pilocytic astrocytoma, and it is important to recognize this variant of pilocytic astrocytoma for the simple reason that it has got an aggressive course, and sometimes it can present with leptomeningeal spread. So what are the things which are not there in this tumor that we can differentiate it from the pilocytic astrocytoma? And that is, 1, we are seeing monomorphic cells in it. 2, there is myxoid background with angiocentric arrangement. 3, there is lack of rosenthal fibers and eosinophilic granular body. WHO has not given any definite grade to it yet. But in literature you can find some of these tumors graded as WHO grade 2. So that's fine. All right. Having said about those 2 gliomas which are well circumscribed, let us go on to the next WHO grade 1 tumor, which is subependymal giant cell astrocytoma. I want you to see this squash preparation very carefully. Look at this giant cell. But seeing this giant cell, don't get alarmed. Don't think I'm seeing a high-grade glioma. No. If you see the other cells which are there, they are polygonal. Some of them do look like ganglion cells. You can read permanent nucleoli, vesicular nucleus. And then, of course, you can see that there are these cytoplasmic processes coming. So it is an astrocytic tumor, yes. But it is showing a lot of pleomorphism, but no mitosis, no necrosis. The location is typical. There is a small mural nodule inside the lateral ventricle. So if you have all this information with you, you can give an impression of subependymal giant cell astrocytoma. This is the paraffin section. As the name indicates, you have lots of giant cells, you have these ganglionic looking cells, polygonal cells, spindle cells. All right, so you see these cells. So what I'm trying to say is you are seeing these very bizarre looking cells in this. But if you see carefully, they're not really looking very malignant, isn't it? They don't have that coarse chromatin, hyperchromatic nuclei. They don't have it, all right? So, in addition to the histomorphology, it is very important to corroborate the findings, your radiological findings to come to the right diagnosis in this case. So, subependymal giant cell astrocytoma is a grade 1 tumor typically located in the lateral wall of the lateral ventricle adjacent to foramen of Monro. It is associated with tuberous sclerosis, but remember, I have seen many cases where there was no history of tuberous sclerosis. So it is not necessary that in all the cases of SEGA, you are going to find tuberous sclerosis. Sometimes it can be the first presentation also. Now, those SEGA which are inoperable, this mTOR inhibitor has given very promising result and one can use it. So now we are going on to these giant cells, giant cell morphology tumors. So first we talked about SEGA. Next is pleomorphic xanthoastrocytoma. Now this is WHO grade 2 tumor. So this was again around a 16-year-old boy. He had a tumor in the temporal lobe. There was a 6-year history of chronic seizure. It was superficially located tumor. There was a solid and cystic component. It was well circumscribed. And this is the paraffin section. What do you see? So you see the name of this tumor. The name is pleomorphic xanthoastrocytoma. So it has to be pleomorphic. It has to show xanthomatous change and it has to be astrocytic. So if you see this tumor, you are seeing that there is a lot of cellular and nuclear pleomorphism. Some are polygonal, spindle, multinucleated, all right? And then you can see this eosinophilic granular body. So that's very important clue. Whenever in a glioma, you are seeing eosinophilic granular body, one must remember that that's a feature of a low-grade glioma, all right? So when you see eosinophilic granular body, plenty in a tumor, how much ever it is showing pleomorphism, please keep your guard and you must remember that, am I dealing with a low-grade glioma? So therefore, you will do further test so that you can arrive at the right diagnosis. So these tumors can also show lymphocytic infiltrate. They are GFAP positive. So this is a reticulin stain. So when you see a glioma, which is showing a lot of pleomorphism, giant cells, and some of the cells are also showing, look at the cells. There is xanthomatous change in the cytoplasm, all right? Look at the cell. So there are vacuoles in the cytoplasm. So this is a xanthomatous chain. But let me tell you, you really have to, if you're lucky, you can always find these xanthomatous cells. But many a times you really have to look for it to find that one xanthomatous or two xanthomatous cells, present here and there. All right. So that means you have to know the whole morphology properly to come to the right diagnosis. So what you have to do whenever you see such kind of histomorphology, do a simple reticulin. And this is one of the tumor which is reticulin rich. Can you see these reticulin fibers which are traversing throughout the tumor? So it is a reticulin rich tumor. And remember one thing, there are only couple of gliomas which are, one is ganglioglioma, another is pleomorphic xanthoastrocytoma. I just want to mention one thing, that in gliosarcoma, you can see retic-rich and retic-poor areas. Remember, it is the sarcoma component which is retic-rich and the gliomatous component is retic-poor. So, otherwise, gliomas are always reticulin poor. So, see, a simple, stain can really clinch the diagnosis. So pleomorphic xanthoastrocytoma is a superficially located, predominantly supratentorial, involving leptomeninges glioma in children and young adults, and there is usually a long history of seizure. What you see is pleomorphic cell, tumor giant cell, xanthomatous cells, eosinophilic granular body, and as I told you, the tumor is reticulin rich. You must remember the mitosis is negligible. 50 to 78% cases of PXA show BRAF V600E mutation, IDH mutation, which is mostly present in the diffuse astrocytoma, is absent in pleomorphic xanthoastrocytoma. Now that I have told you about pleomorphic xanthoastrocytoma, I think it's right to talk about anaplastic pleomorphic xanthoastrocytoma, which is there in our revised fourth edition. This picture is taken from the WHO fascicle, it's not my case. So, what you see here again is these xanthomatous cells, you see these pleomorphic cells, giant cells, but then there is some foci of necrosis and brisk mitotic activity. All right. So, there is a definite criteria to diagnose anaplastic PXA, and that is more than equal to 5 mitosis per 10 hypa field or necrosis plus minus. So, what you have to remember is look at this fourth picture. Can you see these cells? These cells are looking rhabdoid like, means they're polygonal, they have got some eosinophilic cytoplasm to it. So, these kind of cells you can see in anaplastic PXA. So, anaplastic PXA, which is WHO grade 3, can manifest at the initial diagnosis or recurrence. But most of the time, it is the recurrent tumor which is anaplastic. Focal, so how do you diagnose anaplastic PXA? How do you suspect that this is anaplastic PXA? Is that you will see some areas which will be resembling like a typical PXA, and you will see the presence of eosinophilic granular body. And that will tell you that you are dealing with a grade 3 anaplastic PXA rather than a GBM. All right. Then the location is similar. The presentation is similar like grade 2. Even, the radiological details like circumscription, that also is there in WHO grade 3 anaplastic PXA. BRAF V600E mutation is less common than typical PXA. 5-year survival significantly worse than grade 2. Now, since I have shown you this picture, look at this picture. Now I am going to deal with tumors which can show you these kind of cells, and how are you going to sort out these cases. We have these overlapping features, and that's how we will, that's what we are going to learn now. So let us go to the next tumor. So what I'm saying, if say you have prominence of epithelioid cell morphology, which I just now showed you, then your differential diagnosis is epithelioid glioblastoma multiforme. Now this was actually a 15-year-old boy, and he had come with a tumor, uh, and this is the squash preparation. All right. And in the squash preparation, I saw these cells. Look at these cells. They are small, polygonal. They have this nucleus which is having coarse chromatin. And look at the cytoplasm. It is dense and eosinophilic. And there is this necrotic background. All right. So, and radiologically, the surgeon told me that, it's going here and there. So I just told them that yes, it's a high grade tumor, but my differential was, and this patient had an acute history. He didn't have a long history of, chronic seizures. No, he didn't have. He had a very, just I think 1 or 2 months duration, history. So I told that, see, on this morphology I have only two differential. Is it it's a high grade tumor, one. Is it epithelioid GBM, or is it an atypical teratoid rhabdoid tumor? Because this morphology, so much of pink cytoplasm, polygonal cells, I think ATRT is good differential for this. So this is the paraffin section of the same tumor, and you can see that there are these cells, same cells here, and in this picture you can't see so well, but they have this propensity again to arrange themselves around vessels, so that propensity is there for this. And you will see brisk mitosis, you will see necrosis. It's a high grade tumor, you'll have no doubt, but the morphology will be epithelioid. All right. And this is the high of the same, and you can really appreciate this pink dense cytoplasm which is there in these tumor cells. So this is an epithelioid GBM. Remember that this GBM, which is a newer variant, occurs in young adults and children. It is a WHO grade 4 tumor, very aggressive tumor with leptomeningeal spread in more than one third of the patients. What is interesting is that up to 50% of them show BRAF V600E mutation. And another interesting finding that they lack IDH mutation. But we know that wild type GBM are much more common than the IDH mutant glioblastoma. All right, then what is the next thing? It shows retained INI1 nuclear expression. Well, that's an important clue, I think, because our differential in this case was epithelioid GBM and atypical teratoid rhabdoid tumor, which shows loss of INI1 nuclear expression. So what you have to remember that epithelioid GBM will show retained INI1 nuclear expression. Another important thing, it will not have eosinophilic granular body or rosenthal fibers. So I think I made myself clear that if you see this kind of morphology, I'll go back to this picture again, then this morphology, I think another differential which was there is anaplastic PXA. And as I told you that both anaplastic PXA and epithelioid GBM, both of them are showing BRAF V600 mutation, right? So how do we differentiate them? So as I told you, anaplastic PXA will most of the time, de novo is rare, most of the time it is recurrent. And even if you see de novo anaplastic PXA, you will find some area which will be resembling like WHO grade 2 PXA. It will show you eosinophilic granular body and it will be mostly well circumscribed, unlike epithelioid GBM, which is an aggressive tumor and it will present with a very short history. All right. So that's about the epithelioid GBM and how to differentiate it from the anaplastic PXA. So next slide. Yes. I just think that all those three pictures, this one and the epithelioid GBM and the one which I showed you, the anaplastic PXA, they look so similar. So the question is that if you do not do further tests on them, if you do not have the right clinical history, if you do not have the relevant radiological details, it is so difficult to diagnose all these tumors in isolation. So what I am trying to emphasizes that you must have all the information with you, histomorphological, molecular, radiological, clinical, to arrive at the right diagnosis in particularly these kind of tumor which are mimics of each other. All right. So this was another small, I think around 3-4 years, and it was there in the front lobe, and this is the squash preparation. And the description is same, the polygonal cells, epithelioid looking, very pink cytoplasm, dense cytoplasm, coarse chromatin. All right, some necrosis in the background. I'm not seeing mitosis in this picture, but I can assure you there were mitotic activity going on in the background. This is the paraffin section of the same tumor. And again, you see not only these polygonal cells, but you're also seeing some of the cells which are spindly, all right? And there is pleomorphism, yes, moderate amount of pleomorphism. And then there are these areas where you are seeing a nice fascicular arrangement of these spindly tumor cells, and they did show mitotic activity. And there was, believe me, necrosis in this case. This is the immunohistochemistry, and you can see that these tumor cells are positive for vimentin, for EMA, GFAP, neurofilament, and there is loss of INI1 expression. This image is from the WHO fascicle again. So this is atypical teratoid rhabdoid tumor. All right. So let's go on to this let us see what all we see in this tumor. So it's a WHO grade 4 tumor. It's a malignant CNS embryonal tumor with inactivation of SMARCB1, that is INI1, or BRG1. And BRG1 is extremely rare. Most of the cases will show you inactivation of SMARCB1. A tumor with similar morphology but lacking molecular genetic confirmation should be classified as CNS embryonal tumor with rhabdoid features. So what am I going to, I'm trying to tell you in this? I'm saying you are seeing a tumor whose histomorphology is like that, even the immunopattern is like that. Radiologically, it is aggressive tumor. It's in a pediatric age group. You have done INI1 and you have also done BREC1, and you're seeing that there is no inactivation of these two. So do not call it as ATRT. You are supposed to call it CNS embryonal tumor with rhabdoid features. In nutshell, I'm trying to tell you, you can call a CNS embryonal tumor as ATRT only if you have demonstrated inactivation of INI1 or rarely BRCA1. So it's a predominantly pediatric tumor in both supratentorial and infratentorial location, immunopositive for EMA, vimentin, SMA, and sometimes for GFAP, neurofilament, synaptophysin, and cytokeratin. Germ cell markers and skeletal markers are typically not expressed. Having given you some information about ATRT, let us go to the next embryonal tumor, which has been included in the revised 4th edition. That is embryonal tumor with multilayered rosette ETMR C19MC altered. All right. So this was a 2-year-old baby, and she came with this cerebral hemisphere tumor, and this is the paraffin section. So what are you seeing? You're seeing there is varied morphology, for one thing which should be noted. All right. So here in this one, you can see that this is the neuropil-like matrix all around. Then you have these cells. Then you have some ganglionic looking cells here. Look at this one. You can see really a prominent nucleoli. It's quite big. All right. And then you have these areas. In this area, you are seeing that there is rosetting. And the cells are very undifferentiated. They have very scant cytoplasm, extremely hyperchromatic nuclei, brisk mitosis. And then there were some areas where you are seeing that there is this, trabecular arrangement of these undifferentiated cells with this stratification, all right, almost like medulloepithelioma, all right, isn't it? And then this is the nu N. Nu N is the marker for, for the neuronal differentiation. So this is strongly positive. And then this is the INI1, and you see that the nuclear expression is retained. So this is another picture where you can see this multi-layered rosette. All right. You see this multi-layering of the undifferentiated cell around these spaces. And then this is Lin28A. This is a surrogate marker which demonstrate C19MC alteration. Okay. So if you see this Lin28 gives a very strong and diffuse cytoplasmic positivity. So this is a tumor which is showing a varied morphology. Some areas were looking like actually, what is that called? Embryonal tumor with abundant neuropil and what is that? Etantia, right? Abundant neuropil and rosettes. And then you also have medulloepithelioma-like feature, and it is positive for this Lin28A. So this is embryonal tumor with multi-layered rosettes, C19MC altered, WHO grade 4. This is an aggressive CNS embryonal tumor, both in supratentorial and infratentorial compartment. It can be found, and it affects predominantly children below 4 years. It can have any morphology or combination of all these morphology, like the embryonal tumor with abundant neuropil and true rosettes. So etantar, ependymyoblastoma, medulloepithelioma. So it can show varied kind of histomorphology. It's a widely infiltrative Tumor can show leptomeningeal spread as well as extracranial invasive growth in soft tissue and extracranial metastasis. Now, any aggressive CNS tumor, embryonal tumor, with multi-layered rosette, which is not showing this alteration. Which alteration? C19MC. And how can you demonstrate it? By a simple IHC with Lin28A. Say you have got a tumor which is showing the histomorphology like the one I showed you just now, but it is not showing you Lin28 positivity, then you do not call it as ETMR C19MC altered. What do you call it? You call it ETMR NOS. All right. So having said about all these embryonal tumors, which I will just this is a glioblastoma multiforme grade 4, and I don't think anyone will have any difficulty in diagnosing this. I just kept this picture just for you to know and to show to you. So anyways, so this is, you can see the palisading necrosis. You can see this is how microvascular proliferation should look like. All right. And then there is so much pleomorphism, and there's a lot of these tumor giant cells. All right. So this is a glioblastoma multiforme, and it is not very difficult to diagnose if you have a typical histomorphology of GBM. All right. So now that we have spoken about different glial tumors and some of the embryonal tumor, the next section I am going to talk about is frozen section. And this picture I have kept just to show you, those giant cells which we were discussing during Saga presentation. And I was telling you that look at the giant cell, but then it is not looking so bad and malignant, and that's why I have kept these two pictures adjacent to each other, so that you can understand that when you get a squash preparation of GBM, how these tumor giant cells are looking. Look at them, they are bad, they are bizarre, they have hyperchromatic nuclei. I mean, no way you can say this is a grade 1 tumor. You can't, because look at this vascular proliferation. Look at these capillaries which are traversing throughout this tumor, right? And then there is a necrotic background here and there. And now let's go to this. This one is looking so benign and so quiet, right? Not like this. We have a giant cell, yes. Look at these neighboring cells. They don't look malignant. They are looking quite decent, in fact. And then you have these ganglionic cells. All right. So what I'm trying to emphasize is that when you see a giant cell, you are supposed to see the cytomorphology, the nuclear features of the giant cells carefully, the chromatin. I mean, then you have to decide, am I seeing a malignant tumor giant cell, or is it the giant cell which can be of a lower grade, astrocytoma? All right. So this is the difference. All right. So now no more diagnosis up there. I want you people actually to look at these pictures and tax your mind a bit. So this was a case of frontal lobe tumor, and the surgeon said that I'm seeing a tumor, and he sent me a he sent me a frozen section, and this is the squash preparation slide or image. And I'm sorry, this picture is not so bright and nice, but at least you can make out that this is the glial matrix, right? And look at these cells. These are all astrocytes here and there, maybe some oligodendroglial cells here and there. But they are so apart, they're so small. And this is nothing, I think, is this a tumor? Answer is no. This is just white matter. So then I tell my surgeon that there is no tumor in it. So he says, okay, then I'm sending you more. This is my second slide. So this is the second sample. What are you seeing in this? Yes, I'm seeing it's busy. It's not as silent as the first one. This is a busy slide. But what do I see? I see that yes, there are some of these cells. And they look reactive gemastocytes. Why not tumor gemastocytes? The reason is they have got a very small vesicular nucleus, and the cytoplasm, which is sort of merging. They do not have a well defined boundary to it. And then you see this is a macrophage here, another here, and maybe some lymphocytes here and there. So I tell my surgeon, here also, you look at this. No, I'm not seeing a tumor. I'm seeing some inflammation and some reactive gemastocytes here and there, and some amount of white matter. So I want all of you to look at this picture very carefully after I finish my lecture, because you must know that how a normal a slide of gray matter looks, white matter looks, reactive astrocytosis looks, reactive gemastocytes look, because then only you can differentiate it from the tumor. Otherwise, you might give a wrong frozen diagnosis. For example, in this, you see these gemastocytes and you say, yeah, this is a glioma. If you say that, he will just close it. And then when the paraffin section comes, you say there is no tumor. Your life will be in trouble then. All right. So now the surgeon says, okay, then what to do? I said, I think you are in the periphery. If possible, can you give me slightly deeper tissue? So this is what he gives me. All right. So now let us see this slide again. I'm sorry for the quality of the image. It's not so clear. But yes, I think you can appreciate that there are some cells which are bigger. You can see this cell. Now, always compare the cell with its neighbor. So if you see this cell, for example, this cell, and look at the neighbors, they are small. And look at this cell, look at this nuclei. This is 4 times bigger than this. So this is not normal. It cannot be normal. And look at the nuclear margin. It is so, you see, corrugated sort of. Normal astrocyte looks like this. Look at this, round, small, all right? Tumor cell is this. So now what will you tell? You will say, this is an infiltrating edge of a glioma. You cannot grade it, all right? You can only say this is an infiltrating edge of glioma. And believe me, that's enough for the neurosurgeon. He knows he has to go slightly deeper and take more tissue and make your life easy. All right? So this is one. These 3 images, I think is not difficult. Now that I have shown you how white matter looks, how reactive astrocytosis looks, how reactive gemastocytes look. So if you look at this image, what is your opinion? That this is a glioma, because look at these cells. Look at these cells, right? They are all bad. They are large. They have got enlarged nuclei. They have got irregular nuclear margin. They have got Crow's chromatin. All right. So this and this, if this is a low power picture, and in this you are seeing this is a normal cell. All right, normal astrocyte. So you have to always compare it with your adjacent cells, particularly when you are not seeing, totally a tumor. You are seeing an edge or something. That time you have to be very careful, and you should always compare it with the adjacent cell and see this cell, and then you go to this cell. So you are dealing with a tumor, with a neoplasm. So this is actually an astrocytoma infiltrating glioma. And this one, yes, if I tell you, I'm sure you will also start imagining like me. If you see these tumor cells, they are roundish, right? Yes, they are roundish. They're not like this, if you see this. They are roundish, but they are bigger. They have hyperchromatic nuclei, and there is some kind of a glial matrix there in the background. So this is a squash preparation of oligodendroglioma. I can sometimes confuse it with lymphoma. That is there, all right? But I have one more slide in which I'll tell you how lymphoma looks, and I am hopeful that it will clarify your doubt. This is an interesting case. I got this, I think, 2 weeks back. This was a 60-year-old male. He had a cerebellar tumor, and sorry, I think I gave you the hint. So this is a tumor where this is a squash preparation. And what do you see here? You see that there are these small round cells which are all together in one side. And then you have this kind of white matter-like area, right? So is this blue-looking focus small blue cell tumor. This is the high part view, all right? No, this is cerebellum. And what is this? This is a Purkinje cell. Hmm? So you have to be very careful whenever there is a squash preparation from cerebellar hemisphere. The reason is that you always see these granular cells from the cerebellar hemisphere and never confuse them with malignant round cell tumor. And how do you do that? Look at these cells. These cells are so small, they are all almost equal sized. Then you will see that it is very intimately intermixed with this molecular layer, if you call it, or the white matter sort of. And then you have this Purkinje cell or some neurons, you will find it. If you look for it, if you have that in your mind, you will find it. So whenever you get a cerebellar tumor, my advice to you, all the youngsters, is that you must be very careful in giving the frozen section report on a cerebellar tissue. Do not interpret the granular cell layer cells as lymphoma or as malignant round cell tumor. All right. So you have to be careful. So these are the clues which I just now told you. So this is what I told him. It is cerebellar tissue. I don't see any tumor here. And then, and actually his radiological or clinical diagnosis was lymphoma. So now this is, he said, all right, I'll send you more tissue. So this is the more tissue. So what do you see in this? Now I see cells which are round, yes, but they are large, right? There is high N is to C ratio. The nucleus is hyperchromatic, coarse clumping of the nuclear chromatin you are seeing. All right, there's slight necrotic background. The cells are lying singly here and there, right? You're not seeing that, the one which I showed you, the oligodendroglioma. I'll just go to that picture just to help you in differentiating. Look at this. This was oligodendroglioma. Let's go to the next one. Yeah, so this is the lymphoma. Aren't they different? I think they are very much different. All right, so this is, I told him, this is a lymphoma. Okay, so this is how you have to see the cerebellar, interpret the cerebellar tumors. Now, there is one more picture which is just adjacent to it. My question, actually, when it is an online lecture, it is so difficult. I keep asking you question and I keep answering myself. All right. So this second picture, what do you think? Is this also lymphoma? It's not, because if you see this one and this one, there is a difference. And what is the difference? One, you see there is some kind of pink material which is there in between the tumor cells. One. Two, there is a sort of pattern to it. All right. Three, these cells have got some kind of a molding, right? Of course, this also has got high N is to C ratio. It is also got high N is to C ratio, but these nuclei have got some kind of pleomorphism. Some are ovoid, some are slightly spindly, some are round. They have nuclear molding, and they have this pink material in between. So this is a squash preparation of medulloblastoma. This one is not difficult, I think, because you can really see the rosette, Homerite rosette here, and you know that this is a medulloblastoma. So we come to the end of my lecture. Thank you very much. And if you have any questions, please ask. Chat box.
Hello. We have a lot of questions from
Is
the
it
YouTube.
YouTube? So how do I go to
I'll,
that?
I'll, I'll read it. I'll read it for you. Just 1 second. Just give
Okay,
me a
you'll read.
minute.
I can answer it just like that. That's
Yeah.
all right.
Yeah.
He will read. He will read.
So the first question is from Dr. Maria Shahid. She says, how to differentiate anaplastic PXA from ATRT?
All right, good question. So one thing, as I told you, you never diagnose anything in isolation. You must have the clinical details. You must have the radiological details, and then, of course, you have to see the the slide, histomorphology is also very, very important. So in an anaplastic PXA, you will generally see an area which will be resembling like PXA. And what did I say in PXA? You see those pleomorphic cells, you see xanthomatous cells, you see giant cells and lymphocytic infiltrate, and very importantly, you see eosinophilic granular body. So that part is there. And in addition, you have those epithelioid cells. All right. And then what happens next is that if you do INI, it will be retained in it. All right. And then you can do BRAF mutation. So many things are there which you can do to come to the conclusion. Whereas if you see the ATRT, it is it is one is that it will also show you varied morphology. It will show you epithelioid cells. It will show you spindle cells and all that. But this histomorphology in the anaplastic PXA will show you PXA-like morphology as well as epithelioid. However, in ATRT, you will not see PXA-like morphology. You will not see EGB, but you will see polygonal epithelioid cells. You will see spindle cells, and the INI expression will be lost. That is such an important clue. And then, if you want, you can do BRAF also, V600 mutation. I hope I have answered your question.
Yeah,
Is it
yeah,
okay?
very, very clearly, very clearly. If you can just, stop sharing your screen, then everybody can see you on YouTube
Is
directly.
it?
Yeah.
Come, come, go, escape
Can you
twice.
just escape and then
Escape twice, then. All right.
stop sharing?
Stop sharing this. Stop sharing my thing. Then people can
Yeah.
see me.
Yeah. Great.
Yeah,
Now
is
you
it
are on
okay?
screen. Yeah,
All right.
perfectly all right. Yeah.
All right.
Now
Yeah.
there is another question
Hmm.
by Hanan Akli. Says, good evening, everyone. How to distinguish gliosis from tumor proliferation in the absence of ATRX and IDH1?
All right. So I'll just repeat her question. She's telling how to differentiate reactive gliosis, right? Reactive
Correct?
gliosis, that's what is her question. Gliosis means she's, I think, referring to reactive gliosis from
Right.
tumor proliferation, right?
Yeah. In the
Yes.
absence of ATRX and IDH1.
Yes. See, the one frozen section which I have shown you, I showed you in the frozen section where I was showing you reactive gematocytes. They look very different. Okay. And you will react in a diffuse astrocytoma. You will see one, there will be nuclear enlargement. Then there will be, these nucleus will be, they will be lying side to side. They will be, they will what do I say? The gap between the cell is reduced. Okay, so they are overlapping sort of in a malignant, or you can say neoplastic process. The astrocytes, even if they are small, they are small, but there will be enlargement of nuclei. Okay, and there will be nuclear membrane irregularity. There will be overlapping of the nuclei. These are some of the subtle features which you can see in a low grade glioma versus reactive gliosis. But yes, now that we have IDH, it has made our life easier, and we can do IDH and it can help us. But earlier, when IDH was not there, that's how I used to do it. But then again, you have to discuss it with the neurosurgeon, you have to discuss with the radiologist, and you have to see the post-op pictures also, and then you have to inform the neurosurgeon whatever you're thinking.
Great. Hello.
Yes.
Yeah. There is another question from the same person.
Yeah.
It's basically a comment sort of
All
thing.
right. Okay.
Anaplastic astrocytoma can be suggested in the presence of a single mitosis on stereotaxic biopsy without cytonuclear atypia.
All right. So what happens is on a stereotactic biopsy, even a single mitosis is important. You're right. Yes, but we always do MIB labeling.
Okay.
That's a basic thing which we have. Basic immunohistochemical panel, which I'm sure all the labs have, and we do MIB labeling. And if it is more than equal to 5%, we call it anaplastic astrocytoma.
Another question from the same person is for the mitotic index, do we
Hmm.
take into account only atypical mitosis or even normal mitosis are included?
All type of mitosis. There is nothing like, there is no reference that atypical
Yeah.
mitosis in a hot spot is very important. All right. Sometimes what happens, you have to, if you see mitosis, if you can find some hotspots, that is important. But hotspots is more relevant to MIB labeling index. And as is your question, no, there is no such thing as atypical or normal or something. Mitosis is a mitosis in a brain tumor.
Right. Now, another question by the same person is, what are the histological grading criteria for ependymoma WHO grade 3? Is there a consensus on that?
As I told you, see, I am not going into ependymoma thing, but just to answer your question briefly, not going into the details. Actually, there is no definite thing which has been proposed, but yes, WHO does say that when you see more than 20 mitoses per 10 hyperfield, or and you're seeing microvascular proliferation, you are seeing necrosis, geographic necrosis, and it's very cellular, you can call it anaplastic, WHO grade 3 ependymoma. But as I
Mm.
told you, that more than this WHO grade, which is based on these features which I have told you, now the prognosis or the biological behavior of the ependymoma is determined by its anatomical location and molecular subgrouping, and that's important.
Right, right. Absolutely correct. Yeah, another question by Dr. Minesh Gandhi.
All right.
Your experience with granular cell astrocytoma and how to diagnose on frozen. Good one.
A granular cell, oh, I don't have much experience. Granular cell astrocytoma, no, I don't have much experience in this. I don't know.
Yeah.
Sorry.
No, no
Yeah.
problem.
Yes.
Yeah, there is another question by Dr. Maria Shahid. What is
Yes.
the interpretation of P53 in gliomas?
Yes.
Any
So
cutoff percentage
no,
or
there is
all
no
or
such.
none rule?
Yeah, it is all or none rule. Like, if you are seeing diffuse and strong positivity, that is something which must be taken into consideration. Diffuse and strong positivity actually impact, that impact. Now one of the thing also recommendation is that if you are seeing loss of ATRX and diffuse and strong positivity of P53, and the histomorphology, you are confused, is it an oligoastrocytoma, right? And you want to do 1p19q to be certain whether it is falling into oligodendroglioma category, or is it astrocytoma, right? So what the CIMPACT thing is telling is that if you see histomorphology where you are thinking it is oligoastrocytoma, but if you see there is ATRX loss and there is diffuse and strong P53 positive, there is no need to do 1p19q co-deletion status analysis. You can just call it as astrocytoma.
Very nice. Now, I think that's too many questions you have taken. And first time we have had so many questions from the
Oh,
YouTube
thank
being
you so much.
answered
I'm delighted.
straight away. Now, let me just read out some of the comments. We'll go one by one. Deepthi Reddy says, very nice session, ma'am. Thanks a lot. Manoj Kahar says, excellent lecture, too good, ma'am. Very crisp and very clear. Shruti Gobar says, very informative and practical approach to tumors. Thank you so much, ma'am.
Thank you.
And then we have Achal Tandon. Thank you so much, ma'am. Sri Chitra Kartha. Hi, ma'am. Thank you for your wonderful lecture. Maria Shahid. Thank you so much, ma'am, for an excellent lecture. I think it has been a wonderful lecture, and I would like to thank you for taking it up and agreeing to give a talk on such a very complicated topic and making it so simple for everybody. Thank you so much, Amia Junjunwala from Calcutta. She says excellent lecture, and indeed it was a wonderful lecture, and I think people will see it again and again on YouTube. We will put up the recording on the YouTube as well as on the Telegram groups for everybody to watch. Please share your PDF so that everybody has a document to refer to. Thank
All
you
right.
so much, Dr. Ghoshal. Excellent presentation. God bless you. Thank you so much. Good night. Bye bye, everybody.
Bye bye. Thank you, Dr. Nadeem, and thank you to all my students and some of the consultants who are there. And I'm very delighted that I could clarify some of